Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen, and I thank you for listening today. As always, go check out reallifepharmacology.com. We've got the free 31-page PDF on the top 200 drugs. Simply an email will get you access to that, so no-brainer to go snag that. Today's episode is sponsored by meded101.com/store. We've got tons of resources for anything from nursing to pharmacy technicians to pharmacists to prescribers. Go check out all those resources there. Your purchases and support go directly to help support this podcast. So I greatly appreciate that. Again, that's meded101.com/store. All right, the drug of the day today is Irbesartan. Brand name is Avapro. This medication is classified as an antihypertensive. So naturally, it's going to be used to lower blood pressure. That is going to be the primary use that you're going to see this medication used for. Now, it can be used for a couple other indications, reduction in the risk of proteinuric kidney disease. You may see it off-label alternative to ACE inhibitors in things like heart failure with reduced ejection fraction or acute coronary syndromes, for example. So a few other indications you may see it used for, but again, primarily we're going to see it utilized for the management of blood pressure. Its classification. So as you could tell by the ending of the generic name, Irbesartan, so S-A-R-T-A-N, sartan, that's going to be an ARB, so that's an angiotensin receptor blocker. And mechanistically, what does this do? So by blocking angiotensin 2 from binding to the angiotensin 2 receptor on vascular smooth muscle, that's basically going to cause vasodilation. So angiotensin 2 itself is a potent vasoconstrictor. So with this medication, we're trying to block that action and essentially cause vasodilation or less vasoconstriction, whichever way you want to see it there. In addition, it does prevent, kind of down the line, it does prevent aldosterone secretion. And this also helps to prevent sodium and water retention. Okay? So again, as we retain sodium, as we retain water in the body, that blood pressure can potentially go up. So this medication can help prevent that or reduce that sodium and water retention and lower blood pressure that way as well. All right, dosing of this medication, it is nice, and that is typically given once daily, which is ideal. Oral medication, obviously, dosing range 150 to 300 milligrams once per day. That's the usual range I've seen used out in practice. Caution, adverse effect profile. I guess we'll stick with cautions here first. So pregnancy. This can cause injury and even death to a developing fetus. So this medication needs to be stopped as soon as possible when pregnancy is identified. And typically in patients of childbearing age, we're probably not going to use an ARB or an ACE inhibitor for that matter as a first-line antihypertensive medication. Okay. Now, there may be rare cases where, pregnancy is not likely to happen or something like that, where you may see this medication utilized in that patient population. But typically, if somebody's got hypertension, we're probably looking at other alternatives if possible, if they're in that childbearing age for females. The other thing to pay attention to is a history of angioedema. It's not real common with patients, but if patients do have that history, this is a medication that you're going to want to be a little cautious and maybe extra careful if we absolutely have to use this medication in using it in that type of patient with that history. All right, let's jump into adverse effects. Hyperkalemia, so elevations in potassium. Definitely got to know that one. This medication can be used for proteinuric kidney disease and kind of reducing, preventing, delaying that progression. But it also can cause renal impairment issues. So that's kind of a fine line we got to watch, and we monitor renal function. And typically that cutoff is if you get a greater than 30% increase in creatinine or I guess, a reduction in that, GFR, creatinine clearance, that's really the time to start paying attention and say, hey, are we, potentially doing more harm than good with this medication? So if you see that significant drop in renal function, when this medication is started or increased, that's probably a time to kind of reassess, be concerned. We're probably going to recheck some lab work and then, make further decisions. But again, kind of depends upon the severity of that drop that goes within that clinical decision making. So hyperkalemia, renal impairment is a risk. Again, not something that happens crazy often, but something that can. Hypotension. So we're trying to drop blood pressure with this medication, so obviously we can drop it too far. Typically, that's more of a concern in our elderly patients usually. Dizziness can certainly be associated with that. Rarely, you may see some headache. Cough is listed, I believe, but again, that's probably going to be more so with their cousins, the ACE inhibitors like lisinopril, for example. And then that angioedema, that would probably be classified on the severe but rare adverse effect profile. Remember, when educating patients, talking to them about angioedema, probably our biggest concern is the swelling of that airway. So, the tongue, throat, things like that. That's going to be an emergency type situation. Treatment of choice, typically, at least the initial treatment of choice, is going to be that IM epinephrine. So EpiPen, for example, is something that you may see utilized for the management of angioedema. So again, that severity is going to kind of be assessed. If there's, cause for significant concern or some signs and symptoms that, aren't very comfortable, that's an emergency type situation. It's better to err on that side of caution if you think patients are experiencing this with this medication. Monitoring parameters are pretty straightforward. I've alluded to them already. We're going to monitor blood pressure. That's what we're using the medication for, and we don't want it to get too low. Potassium levels. This medication can cause those potassium levels to go up, so we'll keep tabs on that, of course. And then renal function, we're going to monitor creatinine and eGFR and all that good stuff. All right, pharmacokinetic standpoint, onset of action is fairly quick, usually within an hour or so for that peak effect, maybe a little bit more, but around an hour. Duration of action, it is, in the neighborhood of 24 hours or longer. So that's why we can get away with once daily dosing, which is a really nice advantage for a medication to have. That half-life in the neighborhood 11 to 15 hours. And, those are probably the biggest points from a pharmacokinetic standpoint there. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material, if you're looking for clinical education on drug interactions, polypharmacy, if you're looking for something fun to do, nursing pharmacology crossword puzzle book, NAPLEX crossword puzzle book, pharmacy technician crossword puzzle book, go check out meded101.com/store. We've got links to all these resources that can help you better prepare for board exams as well as practice as a real-life healthcare professional. So go check that out, meded101.com/store. Support the sponsor and directly help support this podcast and keep it free and available for all to benefit from. All right, wrapping up with drug interactions. Aldosterone, pretty rarely used medications. ACE inhibitors, very, very commonly used medications. We don't want to use ARBs with these medications typically. It increases that risk for hyperkalemia. And again, it really works in the same pathway in the body, physiological pathway in the body. So don't use a drug like irbesartan with an ACE inhibitor, for example. Not a good thing to do. And that hyperkalemia risk is the primary reason there. But again, we're kind of doubling up on that pathway as far as a mechanism of action standpoint goes. All right, other drug interactions. I do think about NSAIDs and diuretics, and that's from a renal function standpoint. So that's kind of that trifecta that can increase the risk of damaging the kidney, can increase the risk of that creatinine going up. So monitor that very, very closely. Definitely see a lot of people on ARBs and diuretics together. It's something we commonly do on the management of hypertension. And with many NSAIDs, naproxen and ibuprofen being available over the counter, that's definitely a situation I've seen encountered working with patients a lot. So pay attention to that. Make sure we're monitoring renal function. I would say minimize the NSAID use as much as possible. Particularly if blood pressure is well controlled and the patient's doing really well on that regimen of let's say a thiazide and ARB like irbesartan. If that combo is going well, I would lean towards trying to reduce the use of the NSAID as much as possible. And of course, we're going to want to be monitoring that renal function over time as well to make sure we don't put that patient into more of an acute renal failure type situation. The potassium drug interactions we need to pay attention to. So any potassium-sparing diuretic, aldosterone antagonist, spironolactone, that's probably the most common medication that can increase that risk for hyperkalemia. We also have other drugs, one specifically I'll mention, trimethoprim, antibiotic. It's part of Bactrim, part of the combination antibiotic of Bactrim. This can cause elevations in potassium. So having that on top of an ARB like irbesartan, that can kind of double that effect of that hyperkalemia risk. And it's definitely something I think we should pay attention to. I've seen an ER visit because of trimethoprim on top of medications that raise potassium. So keep tabs on that. Lithium. So psychiatric medication, typically going to be used for bipolar disorder. Irbesartan can raise lithium concentrations, and this is one of those kind of sensitive medications. Lithium is narrow therapeutic index, where it's got a kind of a tight window between subtherapeutic or under treatment and toxicity. So we got to take a look at that. Pay attention to lithium for sure, and then kind of the additive and opposing effects. So anytime we add a blood pressure lowering medication, PDE5 inhibitor, Sinemet, even medications like alpha blockers and antipsychotics that have alpha blocking activity that can cause some hypotension. These are all medications that could potentially have that additive effect of dropping blood pressure. So got to pay attention to that. Obviously, patients at risk for that are elderly patients, or at higher risk for that are elderly patients that may be more at risk for falls and things like that. And then on the flip side, we've got medications that can raise blood pressure. So, we don't want to counteract what we're trying to do with irbesartan. So medications like stimulants, so your ADHD medications, for example, Sudafed, so that's a decongestant, systemic decongestant, pseudoephedrine. NSAIDs can even have some blood pressure raising effects and may kind of counteract what we're trying to do with irbesartan as well. All right, well, I think that wraps up the podcast for today. Thank you so much for listening. Do me a huge favor, leave a rating, review on iTunes or wherever you're listening. I greatly appreciate that. Share the podcast, help us grow it. Greatly appreciate that as well. If you got any comments, suggestions, feel free to reach out to me, mededucation101@gmail.com. You can connect with me on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. Thank you so much for listening. Take care, and I hope you have a great rest of your day.